Hello everyone, welcome to another session of next Saviours Essential Question Series NEET PG 2025, where we are going to have a discussion on the larynx and thyroid as far as clinical questions are concerned, and how ultimately to reach the point where we can identify that how this clinical question related to this larynx and thyroid could be answered. So let's start with the first question. This is just for the purpose of introduction, that identify the name of the structure which is marked over here. And as you can very clearly, easily identify that it is the cricoid cartilage. The larynx is made up of 9 cartilages, where 3 are paired and 3 are unpaired. So the 3 unpaired cartilages are the thyroid, the epiglottis, and the cricoid cartilages. As you know, thyroid cartilage is made up of a hyaline cartilage and it is responsible for housing the vocal cord. On the other hand, the cricoid cartilage is the only complete ring which is also a hyaline cartilage and it is present below the level of the thyroid. It is actually the foundation of the larynx. The third one is the epiglottis. And epiglottis, as all of you are aware of the fact that it is responsible for blocking the food from entering the airway. Other than this are the paired laryngeal cartilages, which are arytenoid, cuneiform, and corniculate cartilage. The arytenoid is responsible for vocal cord movement, which is rotation and tension. The corniculate cartilage, as you know, they sit on the top of the arytenoids, and cuneiform are the elastic cartilages which are providing structural support. So this is something that you already are aware of. All you have to do is just a quick revision related to these laryngeal cartilages. And yes, one more thing, that what these cartilages are made up of. Like thyroid is made up of hyaline, cricoid is also hyaline, epiglottis is elastic cartilage, arytenoid is a hyaline at the base and elastic at the apex. The corniculate is elastic and cuneiform is also a elastic cartilage. So this is something that you have to remember, because other way around the question can be asked that they can highlight one structure and then they can ask you what is the name of the cartilage this skeleton is made up of. Next, coming on to the laryngeal muscles, because ultimately the clinical questions start getting to be asked from this topic, that is laryngeal muscles. All of you are aware that the laryngeal muscles could be divided into two. One segment is intrinsic and the other one is extrinsic. And among the intrinsic muscles, the first one is the cricothyroid muscle, which is extremely important because of the sense that it is the only intrinsic muscle which is not supplied by the recurrent laryngeal nerve. And all of you know the function, that it is responsible for tensing the vocal cord. That means high pitch is a responsibility. High pitch voice is a responsibility for cricothyroid muscle. Then comes the thyroarytenoid muscle. The thyroarytenoid muscle is responsible for relaxing the vocal cords. So it is responsible for producing low pitch sound. So low pitch sound is a feature of thyroarytenoid muscles. Now, posterior cricoarytenoid, this is also anatomically important, because posterior cricoarytenoid is the only muscle which is abductor. So it is responsible for opening the airway. While lateral cricoarytenoids, it is adductor of the vocal cords, which is responsible for closing the airway, and the transverse and the oblique arytenoids are also responsible for closing the vocal cords tightly. So these are the functions of the intrinsic muscles of the larynx. As you know, extrinsic muscles can be divided into two, like suprahyoid and infrahyoid. Suprahyoid are responsible for elevating the larynx, while infrahyoid is responsible for depressing the larynx. So this is something that you are aware of. Like a 45-year-old male presents with the hoarseness of voice for the past 3 months. There is a denial of any history of smoking or recent upper respiratory tract infection. Laryngoscopic examination reveals a paralyzed left vocal cord in the paramedian position. Now, injury to which of the following muscle is suspected responsible for the patient's symptoms? Paralysis in the paramedian position suggests a lack of vocal cord abduction. So there is a loss of abduction of the vocal cord. And the only muscle responsible for abducting the vocal cord, that means opening the airway, is the posterior cricoarytenoid muscle, which is supplied by the recurrent laryngeal nerve. So if this muscle is paralyzed, the vocal cord remains in the paramedian position, leading to hoarseness, and in bilateral cases, there will be a striga. That means there will be an airway obstruction. So probable answer for this question is posterior cricoarytenoid. We used to tell you that before marking the answer or before jumping onto the answer, it is essential to rule out the other options. So why not cricothyroid muscle? You know, cricothyroid is responsible for tensing the vocal cords. So it increases the pitch of the voice. So if at all cricothyroid is paralyzed, then what will happen? There will be a weak monotonous voice. Why not lateral cricoarytenoid muscle? Because it is responsible for adducting the vocal cord. So that means it is responsible for closing the glottis. So there will be a feature of breathy dysphonia in case where lateral cricoarytenoid is paralyzed. On the other hand, in case of thyroarytenoid muscles, there will be a weak voice, but there will be no paramedian position of the vocal cord because it is responsible for relaxing the vocal cords. So vocal cords remains mobile in this case. There is no paramedian position. The hot zone for the NEET PG examination is the laryngeal nerve supply. You know, the laryngeal nerve supply can be divided into two. One is superior laryngeal nerve and the other one is the recurrent laryngeal nerve. Now, superior laryngeal nerve can further be divided into external branch and internal branch. Now, external branch is a motor branch which is responsible for supplying the cricothyroid muscle. As I told you, that cricothyroid is the only intrinsic muscle which is not supplied by the recurrent laryngeal nerve, while the internal branch is responsible for supplying the supraglottic region above the level of the vocal cords. So, as we have already discussed that if there is an injury to this external branch, then it will result in the paralysis of the cricothyroid, and cricothyroid is responsible for high pitched tone of the voice. So it will result in the hoarseness and monotonous voice. And the patient, for example, the patient cannot sing high pitched tones. So this is what is expected in case of a superior laryngeal nerve palsy. Another one is the recurrent laryngeal nerve. As you know, that all the intrinsic muscles except cricothyroid is supplied by recurrent laryngeal nerve, and it is also a sensory nerve to the infraglottic region, that is below the level of the vocal cords. If the recurrent laryngeal nerve injury is unilateral, then it will result in hoarseness of the voice. But if the recurrent laryngeal nerve injury is bilateral, then it will result in airway obstruction, which of course is an emergency. Now, you know, thyroid surgeries where the recurrent laryngeal nerve, it loops around the thyroid. So it is likely to be injured in this case. Aortic aneurysms, because the recurrent laryngeal nerve, it loops around the aorta on the left side. So it might result in left recurrent laryngeal nerve palsy, while right recurrent laryngeal nerve palsy can be seen in case of subclavian aneurysms because it winds around the subclavian artery, the right one around the subclavian artery and the left one around the aorta. What we are trying is ultimately to reach to a conclusion that how this thing can be related clinically. So this ultimately is the aim of the discussion of the laryngeal anatomy. So first one obviously is if there is a history of thyroidectomy injury provided to you in the question where there is an external superior laryngeal nerve palsy, then think of the muscle which is paralyzed obviously will be cricothyroid, and it will result in the loss of high pitched voice. In case if thyroidectomy results in recurrent laryngeal nerve palsy, then almost all the vocal cord muscles would be paralyzed and it will result in the hoarseness of the voice when unilaterally affected, and when there is a bilateral affection it will result in respiratory distress or a stridor. You know, majority of the times the progressive hoarseness of the voice is the clinical feature provided to you in any question related to the laryngeal cancer, and it is because of the recurrent laryngeal nerve palsy. Now, the cricoid could be fractured in case of trauma, in case of intubation, and it is the only full cartilaginous ring that we have already talked about. So, it might result in subglottic airway obstruction. So, these are the clinical correlations that ultimately we try to bring in order to make the process easier for you to identify. A professional singer undergoes thyroid surgery. Now, post-operatively, she complains of inability to sing high-pitched notes, but her speech is absolutely normal. Which nerve is likely to be affected? Now, it becomes much easier for you to identify. Loss of high-pitched note, that means cricothyroid palsy. And cricothyroid is supplied by external branch of superior laryngeal nerve. So this is the answer for this question. Next is a 60-year-old male with a history of aortic arch aneurysm presents with the progressive hoarseness of the voice. Examination reveals unilateral vocal cord paralysis. And what is the most likely affected nerve? You know, the left recurrent laryngeal nerve, it loops around the aortic arch, so it could be compressed by the aneurysms. That is why it might result in the hoarseness of the voice. The answer for this question is left recurrent laryngeal nerve. Now, in this section, we will try to learn that how these injuries to the nerve of the larynx are associated with thyroidectomy or the thyroid related surgeries. Thyroid gland, which is highly vascular, butterfly shaped organ located in the anterior to the trachea, and there are left and right lobes that you already are aware, which is joined by isthmus. Pyramidal lobe is also present in 50% of the cases, which is a remnant of thyroglossal duct. You already are aware of this, and it has been asked multiple of the time. It is enclosed inside the true capsule, which is fibrous, another false covering, which is pretracheal fascia, and the thyroid isthmus is present or is opposed to second, third, and fourth tracheal rings. So this is basic anatomy of the thyroid that you are already aware of. So before we talk about the nerve injuries that are likely to happen related to the thyroid surgeries, why does the swelling of the thyroid move during swallowing? Thyroid masses, it moves with swelling, while other masses like lymph node and the other masses, they do not. And it is a very important distinctive feature because the thyroid gland is enclosed by the pretracheal fascia, which is attached to the larynx and the trachea. When you swallow, the larynx moves up, pulling the thyroid gland along with it. And this is the useful clinical test for that the thyroid masses, it moves with the swallowing. Based on this, we are having a question. 42-year-old woman presents with a midline neck swelling that moves with the swallowing but does not with the tongue protrusion. Which of the following is the most likely diagnosis? So answer for that question obviously is the thyroid nodule. Why? Because thyroid gland moves with the swallowing but not with the tongue protrusion, unlike the thyroglossal cyst, because thyroglossal cyst, it moves with the tongue protrusion. So this is the key distinctive feature. It has been asked multiple times, so that is why it has been placed. Now, real deal is to talk about the blood supply of the thyroid. Now, you already are aware of the fact that the thyroid gland is supplied by two major arteries. One is superior thyroid artery and the other one is the inferior thyroid artery. Now, superior thyroid artery is the first branch of the external carotid artery, as you already are aware of this fact, and inferior thyroid artery is a branch of the thyrocervical trunk, which is coming from the subclavian artery. The point is that this superior thyroid artery, it runs with the external branch of superior laryngeal nerve. So there is a high risk of high-pitched voice loss in thyroidectomy when you are ligating the superior thyroid artery, or if there is a tractional injury to the external laryngeal nerve. So similarly, the inferior thyroid artery, it runs in close approximation to recurrent laryngeal nerve, and if there is an injury on one side, then it might result in the hoarseness of the voice. This is what we are trying to conclude, that in case of a thyroid surgery, what are the names of the nerves that are likely to be affected and how this thing will be provided to you in the question. Now there is another artery, that is thyroid ema artery, which is rare arterial supply, which come from the brachiocephalic trunk or the aortic arch, and it also bleeds massively if it is sectioned during tracheostomy. So this is what we are trying to deal with, that what is the artery and the nerve relation in related to the thyroid surgeries, like the external branch of the superior laryngeal nerve, because it runs in close approximation to the superior thyroid artery, and if there is an injury, then it will result in the high pitch voice loss. While in case of recurrent laryngeal nerve, it runs in close approximation to inferior thyroid artery, so it will result in the hoarseness. If it is unilaterally injured, it will result in the airway obstruction, that means the stridor, if it is bilaterally injured. That a 40-year-old female undergoes thyroidectomy for the multinodular goiter. Post-operatively, she complains of inability to sing high-pitched notes, but her speech is normal. Which structure was likely to be injured? Now, this kind of the question we have already talked about, but there it was in the context of the nerve injury, and here we are trying to correlate it with the thyroid surgery. So answer for that question obviously is the external branch of the superior laryngeal nerve, which runs with the superior thyroid artery and innervates the cricothyroid muscles, which is responsible for high-pitched voice production. Another question is, a 55-year-old male undergoes total thyroidectomy. Now, on post-operative day 1, he develops hoarseness of the voice. Laryngoscopic examination reveals unilateral vocal cord paralysis. So, which of the following nerve is most likely injured? Then answer for that question is very simple. It is recurrent laryngeal nerve. And recurrent laryngeal nerve, because it runs with the inferior thyroid artery, and in a process of ligating this inferior thyroid artery, there is a possibility that you have injured the recurrent laryngeal nerve on the affected side. And it supplies all the intrinsic muscles except cricothyroid. So, hoarseness is going to be the clinical feature related to this particular one. Whenever the nerve injuries are asked in relation to the thyroid, it is a part of the anatomy. But when they ask you a complication of bleeding, it is basically a question asked from the surgeon. Post thyroidectomy, the hemorrhage or the bleeding is a important complication which can be divided into primary, reactive, and secondary based on the timings, which is during the surgery or within the 6 hours of surgery, which is primary. Reactive is within 24 hours post operatively, but not immediately during surgery. And secondary bleeding is 3 to 10 days post operatively. So these are the common causes which might result in like slippage of the ligature, inadequate hemostasis, large arterial or venous bleeding. Now, for reactive bleeding, there could be a sudden increase in the blood pressure, coughing, vomiting, or straining. While in case of secondary bleeding, infection is the most common cause. Now, what are going to be the clinical features? Means this can be very easily identified. There will be rapid neck swelling, stridor, airway obstruction, and hypovolumic shock if there is a severe bleeding. On the other hand, reactive bleeding is seen as a gradual neck swelling, increasing respiratory discomfort, while the secondary bleeding is revealed like slow, persistent oozing from the wound, the signs of infection, and it rarely leads to airway compromise. And ultimately, what they ask you is the management. That means immediately you have to open the wound bedside, urgent re exploration in the OT, and obviously, because of the risk of the airway obstruction, you have to secure the airway by performing intubation or tracheostomy based on the indications, and hemostasis has to be achieved with ligation or by electrocauterization. For reactive bleeding, you have to first control the vitals and the BP. Now, if there is a worsening of the swelling, then again re-exploration is required. On the other hand, for secondary bleeding, the antibiotics, if at all infection is suspected, IND if there is a formation of the abscess, active bleeding is suspected, then you have to take the patient back to OT for hemostasis. So hopefully everything is clear related to this topic also, as I'm repeating it again, that if thyroidectomy related bleeding complications are asked, that is a question from surgery. If the nerve injuries are asked, that is a question from anatomy. Hope the session might have helped you out in reaching the answer. Not to miss any update, please join our Telegram group. All the best for your future endeavors. All the best for your future examination. Stay healthy, stay fit.